So, Dr. Dacheux is a friend and colleague. We've met and some of her team in Paris over the last year. I think you're going to be hearing some very exciting things coming forward from France, from Necker Children's Hospital, Ramsay, Santé Générale, and also from a great orthodontic clinic in Boulogne. So thank you very much for being here today. I'm very excited to have you share a new position statement on pediatric sleep from the French Orthodontic Society.
Mrs. President, Mr. President, thank you for inviting me today. I'm very honored to be here to speak with so many experts that I admire, such as Julia Cohen-Levy, who is one of my mentors. And I'm going to talk about the Pediatric OSA. So I do not have any conflicts of interest. Pediatric OSA is estimated between 1.25% and is nowadays underdiagnosed. As a result, the national public health authorities get interested in pathology in view of the implication that this entails. For those reasons, the French ENT Society and the French Federation of Orthodontics published recommendations to improve the screening and treatment of pediatric OSA. In 2017, the French ENT Society issued recommendation about the role of ENT in obstructive sleep apnea hypopnea syndrome treatment care for children, and emphasized the importance of interdisciplinary collaboration, including orthodontics and myofunctional therapy as standards of care to treat children. They affirm that myofunctional therapy is proposed in addition to surgical orthodontic treatment to prevent residual OSA and contributes to stabilize outcome of the surgical treatment when combined with orthodontic treatments. In 2018, the French Federation of Orthodontics also published recommendations about the role of orthodontics in the screening and treatment of pediatric OSA, to which Julia Cohen-Levy and my partner Aurélie Majoureau contributed. The FFO, so the French Federation of Orthodontics, is bringing together 12 different scientific societies listed here, including the European College of Orthodontics and the French Society of Dental Sleep Medicine. A few months later, Aurélie, my partner, and I presented some of those recommendations at the 21st French National Congress of Orthodontics in Paris. Out of these 16 recommendations, 2 dealt with myofunctional therapy. As the ENT Society did, the FFO concluded that in addition to orthodontic treatment and adenotonsillectomy, myofunctional therapy is recommended to correct functional abnormalities, such as mouth breathing, tongue thrusting, tongue puncture, and to prevent relapse of ventilatory disorders. Indeed, ENT surgery and rapid maxillary expansion, by correcting the oropharyngeal structures, will partially improve function, but will not solve neuromuscular disorders. If the patients still have a large and hypotonic tongue after primary treatments, this tongue will tend to obstruct the airways and slide back during sleep. So a meta-analysis showed that the Mabelan-Patty classification and a Friedman tongue position assessment technique that evaluate the tongue compared to the palate were significantly correlated with predicting OSA severity. So if you can control the tongue, you might contribute to prevent OSA, hence the importance of myofunctional therapy. It is also important to strengthen the soft palate after adenoidectomy. Professor Delaire explained that when there is an hypotonic palate, the soft palate, there is a notch on adenoids. But when the soft palate is sufficiently tonic, it pushes back the adenoids. when pushing back the adenoids constantly, the soft palates make them disappear. Hence, tonic soft palates helps to avoid relapse of adenoidectomy. So I would like to thank Professor Delair, who has been my mentor since my residency. He is a real pioneer on OSA, pediatric OSA diagnosis and treatment. And I also thank Dr. Nicolas Gossens, who has been working for years very closely with Professor Delair to develop innovative pediatric OSA strategies. So the FFO concluded that myofunctional therapy significantly contributes to the reduction or normalization of residual AHI after surgical orthodontic treatment and helps to maintain the results in long term. For example, this patient had, before orthodontic treatment, had severe OSA with an AHI of 23. He was then treated by CPAP. And 6 months after rapid maxillary expansion, the AHI decreased from 23 to 6.2 by reducing the nasal resistance and increasing the volume of the nasal cavity. But in order to improve and maintain those results, this patient got myofunctional therapy, and 1 year after orthodontic treatment and myofunctional therapy, the AHI decreased at 4.9. So orthodontic treatment, in addition to myofunctional therapy, improve nasal breathing and in order to stabilize skeletal maxillary expansion and normalize the labial-lingual functions. In our clinic, we use the envelope linguale nocturne, which is a ramp that elevates the tongue towards the palate, and the écran buccal right after rapid maxillary expansion. We have modified the envelope linguale nocturne by clipping it with a French startup called Alenke, by clipping it on the expander. And the envelope linguale nocturne helps the tongue to reach a physiologic position, both during swallowing and in relaxation position, and helps to maintain the growth of the maxilla. And the écran buccal is a buccal shield that stretches the labial muscles and helps the patient to correct mouth breathing. Those appliances, the patient with those appliances at nighttime and for 1 hour during daytime. During the day, the patient has to do breathing exercise with the 3 following rules. Close your lips, tongues up, and breathe through your nose. And of course, if there is a tongue tie, it's also important to allow the tongue to rise to the palate by doing a lingual frenectomy. Myofunctional therapy has to start before frenectomy, carry on the day of the frenectomy, and after surgery. Here is the therapeutic strategy published in the FFO's recommendation. Myofunctional therapy is as important as dietary measures, ENT surgery, medical treatment, and orthodontic treatment, and if an OSA is diagnosed. And after that, a regular follow-up must be done, and in case of severe OSA, CPAP can be proposed by the pneumologist or sleep physician. So in conclusion, in order to optimize the management of pediatric OSA, a collaboration between the different disciplines is recommended. Myofunctional therapy is as an integral part for the pediatric OSA treatment as sleep medicine, ENT, pneumology, allergology, orthodontics, and maxillofacial surgery. In France, when an OSA is suspected, there is a real lack of visibility for the patient and his family and the health professionals to know to which specialist practitioners to refer to. Pediatric hospital sleep centers are also affected with delays that are too significant to meet the demand. For those reasons, the Center for Interdisciplinary Management of the Child Snoring and Obstructive Sleep Apnea Syndrome has been created at the Institut de l'Enfant, located in Boulogne-Billancourt, just nearby Paris. And this center provides a real service to the child and his family by improving the access to early diagnosis and treatment of pediatric OSA. This private center is unique by its partnership with public hospitals like Necker, which are all national reference centers of specific complex pathologies, and all the members of the center are affiliated with those national reference centers and can easily refer the patient to the right team department at their hospital to ensure continuity of care in case of severe pathology. So the aim of these structures are to communicate on pediatric OSA, diagnose as early as possible pediatric OSA, facilitate the coordination of OSA child's care journey, and to promote clinical research. The center is gathering different pediatric specialists, 4 pneumologists, 2 ENT, 1 endocrinologist, 2 orthodontics, and 2 myofunctional therapists. This center is one of the first that formalized the importance of myofunctional therapy in their brochure. And based on our experience, it was really important to have an interdisciplinary team with specialists working together, and not only a multidisciplinary approach where the patient and his family is lost in a ping-pong game between the different specialists. Each members of our team is conscious about the role of the other specialties in intern knowledge. For instance, even if I am an orthodontist, I will look at the patient under the scope of the other specialties. I will look at the tonsils during my clinical exam, at the adenoids on the lateral ceph, mouth breathing, tongue posture, and lip tonicity. And by reciprocity, the NT will check if there is any transverse maxillar discrepancy. And the same for the pulmonologist, endocrinologist, and myofunctional therapist. So in conclusion, mouth breathing is associated with my position of the tongues, which further reinforce impaired development of the maxilla and the mandible, and leads to narrow upper airways and OSA. But if the patient can benefit from early treatment with myofunctional therapy, it is possible to ensure good the normal development of the craniofacial structure, which will allow normal breathing and maybe may prevent OSA. So, as I do really like yoga, please let's have a big, deep breath and a lot of inspiration. Thank you very much for your attention.
So it's very exciting to see such a bold statement from not just the French Orthodontic Society and supported by 12 other societies, and really to see clinicians and researchers partnering with hospitals and other societies building a collective position statement with the European College of Orthodontics to make a bold statement putting myofunctional therapy, even though it's emerging and we have a lot of work to do to professionalize it, to do validation studies, but to see it reaching this kind of status, being in with those specialties and being presented as a first-line treatment, not a third-line treatment after you've failed on CPAP or something like that. So this is really exciting, and thank you for your leadership, and collectively also thank you, France.
Thank you.